Good morning. I am Dr. Jagadishwari, Professor of Pediatrics from Sree Balaji Medical College and Hospital. I welcome you all for the lectures in Pediatrics. Today the lecture is on examination of newborn, and the competencies include 21.7 PE 20.2 PE 20.2.1 22.2 22.3 and 22.4. The specific learning objectives are: first, to know about the importance and need for learning a neonate, examining a neonate. Next, the neonate have to be examined at different times after birth. Third, know what to look for during examination and the sequence of examination. Have an overview of gestation and the neurologic examination. Now we go on to the purpose of examination. Here, to assess the weight, gestation and classify the neonate, look for any evidence of trauma, look for congenital malformations or dysmorphic features, for signs and symptoms of illness, check for normal or common problems associated, and to check if feeding and growth is appropriate, and also identify a sick or at-risk neonate. Next is the examination process. Room should be warm. Warm hands before examining a neonate. First observe the baby. Next examine the baby in supine position. Then put the baby prone and examine the baby. The sequence of examination should be from minimal handling to more handling. If mother or baby feel uncomfortable, pause and then comfort the baby, proceed to examination. Now, the first examination of the baby. This is immediately after birth. Soon after birth, we will be doing a quick examination following resuscitation of the baby and stabilizing the baby. So here are three important points in the first examination: to look for birth trauma and for obvious malformations, and also check the birth weight of the baby. So here I am showing some pictures of the birth injuries. The first is a baby with the forceps mark just above the left eye, and this mark is an impression of the forceps which has caused swelling of the head, and this swelling of two types. One is a cephalohematoma or the caput succedaneum. The swelling in the red color is due to cephalohematoma, and the swelling in blue color is a caput succedaneum. As you see, the swelling in the blue color is due to edema of the presenting part, because it is edema of the scalp, it will cross the midline and it is soft and it disappears within 1 to 2 days. Mostly it appears at birth because of the constant rubbing of the scalp against the hard bone or pelvic bone of the mother. The swelling in red color is due to cephalohematoma, and as the name suggests, the hematoma is collection of blood. This is under the pericranium, mostly below the parietal bone, and this doesn't cross the midline and it is restricted to one side. It may vary in size from small to large, and some very rarely there may be bilateral cephalohematoma. And because there is collection of blood, it takes longer to disappear and may exaggerate a jaundice in the baby. And in the X-ray of the chest, the right clavicle is fractured. This is again one of the birth trauma. And in the X-ray of the whole body, the right humerus is fractured. It is clearly seen. And these are the bony injuries during labor and delivery. The neurologic injury is seen in the picture, a baby having an Erb's palsy of the right upper limb. See, the left upper limb is normal as the baby is able to flex the arm and the fingers, and in the right upper limb the baby is not able to flex the forearm and not able to flex the wrist. Both the elbow and the wrist is extended and the fingers are flexed. This is called Erb's palsy, which is common. It is because of the injury to the brachial plexus. Next, we'll go on to see some of the malformations. The common malformations is seen in the picture. It's a cleft lip of the left side, and there are also, as the mouth is open, see the cleft palate, and the third picture shows the cleft lip and palate. And in the legs, these two legs, both the legs have the talipes equinovarus deformity, and a baby is prone, and this baby has a large meningocele which is preventable by folic acid supplementation given to the mother during the early pregnancy. And in one of the picture, the umbilical cord is shown. See, normally the umbilical cord should have a single vein and two arteries. The next picture, which has a single artery, that is an malformation, and single umbilical artery is associated with renal anomalies or some intrauterine anomalies, intra-abdominal anomalies. So during the first examination, that is soon after resuscitation, we will be doing a quick assessment for birth trauma or malformations, and that is over. Now we will go on to the second examination that should be done within 24 hours of birth. It should be a detailed examination of the baby, the measurement of anthropometry, the gestational assessment, and detailed examination from head to toe, systemic examination, and also we have to assess the feeding of the baby. These are the 5 headings we should do in the examination within 24 hours. First, we'll take up the anthropometry. That is, we have to measure the length of the baby. The normal length is 48 to 50 centimeter. By the infantometer, we will measure the length. That is, these babies cannot stand, so make the baby lie down and measure the head to toe length, and normal 48 to 50 centimeter. Next, we should take the weight of the baby. That should be normal weight is 2.5 to 4 kg. Any baby less than 2.5 kg we call them low birth weight babies, and less than 1.5 we call them very low birth weight baby, less than 1 kg we call them extremely low birth weight baby. How we call a baby more than 4 kg is a big baby. So you should know that different classification according to the weight of the baby. Normal weight is 2.5 to 4 kg. Next measurement is head circumference. Here we measure the occipitofrontal circumference. From the occiput to the glabella, go around with the inch tape. It should be a flexible inch tape, not a metallic one. And the normal head circumference or occipitofrontal circumference is around 35 centimeter. Chest circumference is usually less than the head circumference, that is 2 centimeter below the head circumference, that is lesser than the head circumference. Now we will go on to the vitals. In vitals, you have to record the heart rate, respiratory rate, capillary refill time and the SpO2. Heart rate is 120 to 160 per minute. This you have to record by auscultation. And respiratory rate 40 to 60 per minute. Here you have to record the respiratory rate by palpation. Capillary refill time less than 3 seconds. This records the perfusion of the baby. This is equal to blood pressure. That is by blanching the skin for 5 seconds and leaving it, the refill time should be less than 3 seconds normally. And one more important vital is the temperature of the baby. That is not given here. The normal temperature is 36.5 to 37.5 degrees centigrade and the range of 1 degree centigrade. So below 36.5 degrees centigrade is called hypothermia. Above 37.5 degrees centigrade we call it as fever in a baby. So this again, record the temperature in babies, which is very important. Hypothermia is very common and that will lead to more complications in babies. The last vital is the SpO2. That should be above 92%. Usually it is recorded on the right upper limb. Next we will go on to the systemic examination. To start with the respiratory system, you have to look at the pattern of breathing. Most of the time it is abdominal thoracic. The abdominal movement will be seen obviously, and already we have recorded the respiratory rate. Is the baby having any respiratory distress or chest retraction or any sounds like grunting, and also record the breath sounds, auscultate the breath sounds. In the cardiovascular system examination, you have to record at least the femoral pulse, because the peripheral pulses are not felt. It is difficult to feel the peripheral pulse. So feel both the femorals and know the femorals are felt equally. Next, auscultate for cardiac murmur. Most of the murmurs which are recorded at birth may be a hemic murmur and which may usually disappear. If it is a murmur due to any cardiac problem, we have to record, and that has to be followed with an echo. The abdomen examination, always look for 2 umbilical arteries, and if there is a single artery, we have to do an ultrasound abdomen to rule out intra-abdominal anomalies. And also palpate the liver. Usually the liver is palpable by 2 centimeter, and this is physiologic and it is not because of the enlargement. Next we will go on to the gestational age assessment. The gestational age assessment is done by the new Ballard scoring system. This is got 2 parts. One is the physical criteria, the other one is the neurologic criteria. In the physical criteria, there are about 5 headings: the skin and lanugo, then the examination of the ear for the recoil, breast tissue, the nodule, the nipple and areola, the genitals and the sole creases. So I'll show you some pictures how a preterm and term baby will be looking by physical criteria. Next, by the posture. See, in this picture, the term baby has a flexed posture. This is called universal flexion. And in a preterm baby, it is an extended posture, and this is called frog-like posture because the preterm is hypotonic and has not flexed the limbs. It is frog-like posture. Now you look at the ear. The preterm, there is no cartilage in the ear, so only the skin is present, and if you flex it, the recoil will be very slow in preterm, and in the term there is ear cartilage present in the external ear. If you flex the ear, the recoil is immediate, instant. Next, you see the breast tissue, areola and nipple. Look at the preterm baby. The areola is not visible, nipple is barely seen, and there is no breast tissue. In a term baby, the nipple areola pigmentation is there and it is well seen, and there is breast tissue inside. You may be able to palpate the breast tissue, and mostly in a term baby, it is more than 5 millimeters. Now look at the genitals of the preterm, which is on the right side. The pigmentation rugosity of the scrotum is less, and in a term, the pigmentation and rugosity is very much seen well and it is normal. So to differentiate a preterm and a term male baby, you should look at the pigmentation rugosity of the scrotum. The sole creases. The preterm has very minimal sole creases, that too only the minor creases are seen. In a term baby, the major and the minor creases are seen and it is distributed all over the sole of the foot. That finishes the physical criteria. Now we will go on to the neurologic criteria. Here we start with the posture. Already shown two pictures with the posture of a term and preterm baby. Term baby has a universal flexion. Preterm baby has a frog-like extended posture. Then the square window. The square window is the flexion of the wrist, which is difficult in preterm, and easily you can flex the wrist in a term baby. Arm recoil. You extend the arm. The recoil is immediate. That is, flexion of the arm is immediate in term baby, and it is very slow or absent in preterm baby because the tone of the muscle is poor. Popliteal angle. In a term baby, the popliteal angle is narrow, and in a preterm, the angle is wide because of the hypotonia. Next, scarf sign. As you are trying to put the baby's palm over the opposite shoulder, in a term, the elbow doesn't cross the midline. In a preterm, the elbow will cross the midline because of the hypotonia. Heel to ear. Here, in a term, because of the good muscle tone, you may not be able to touch the ear by the heel. In a preterm, you can easily touch the ear with the heel because of the poor tone in the muscles. See, this is the neurologic criteria and the physical criteria is seen in the picture, and it is starting from 0 to 1, 2, 3, 4, 5, and you have to put everything separately, add it up, and with the score you will easily assess the gestational age in the chart. Next, we have to assess the feeding of the baby. Every baby should start the breastfeeding within 1 hour, and this is called early initiation. By doing early initiation, we will prevent 1 million deaths all over the world. So earlier the initiation, better for the baby and successful breastfeeding. So this is the position and attachment of the baby, that is called latching. In the good latching, the baby's mouth is wide open and you may not see the areola much, and the baby's chin touching the breast, and this is a picture showing all points of the good latching. This we have to check as the mother is feeding and make the mother confident of breastfeeding the baby. And next we will go on to some of the specific problems which a baby may develop in the postnatal ward. During the postnatal stay or in the hospital, these babies may develop the yellowish discoloration of the skin and mucous membrane, that is called jaundice, and this jaundice is usually physiologic, and around 60% of term babies and 80% of preterm babies may develop jaundice, and this jaundice you can clinically evaluate by the Kramer's rule, and this picture shows the Kramer's rule. If the face is jaundice, the level is around 5 mg per dl. If the chest is jaundice, it is 8 to 10 mg. And if the abdomen is jaundice, it is around 12. And legs, it is 14. And palms and soles, it is beyond 15. So with this, you can clinically assess any baby having the jaundice up to the palms and soles. It is not physiologic, and we have to start evaluating the baby for jaundice. And a baby developing jaundice on the first day, and baby having a jaundice up to the palms and soles, and baby's jaundice beyond 2 weeks having a prolonged jaundice, or baby's jaundice is increasing day by day, we call this jaundice as pathologic jaundice. A physiologic jaundice usually appears on the second day and increases slowly, and the peak level doesn't go beyond 12 to 14, usually disappears by end of 2 weeks. This is physiologic. So you should be able to differentiate the physiologic and the pathologic jaundice during the examination. Now, you also know about the danger signs which should be looked into the baby during the baby's examination, because some of the babies may develop some problem. So the danger signs should be lethargy, poor feeding, hypothermia, hyperthermia, seizures, abdominal distension, respiratory distress, cyanosis, apnea, worsening jaundice, skin bleeds, petechiae, persistent vomiting, and diarrhea. These are all the danger signs which has to be informed the mother. If any one the mother notices, should bring the baby to the hospital. And before discharge, we have to go through the baby again. That should be the third examination. And here we have some criteria for discharge. The baby should be gaining weight, should be feeding well, should be able to maintain the temperature, and should not be having any problem as we discussed earlier, and mother should be confident of taking care of the baby. If the baby fulfills all the discharge criteria, we will be discharging the baby. After finishing the 3 examinations, when the babies are getting discharged, we have to have a protocol for discharge, that is, take the discharge weight and record all the detailed examination, the discharge advice, check the breastfeeding, advise the mother regarding the following: exclusive breastfeeding, the follow-up of the baby, immunization of the baby, and the danger signs, to be informed, and that finishes the class on examination of newborn. And thank you all.